Hello, everyone. Thank you for joining us in person, for those of you who are here in person, as well as for joining online today. My name is Dr. Rachel Vreeman. I am a pediatrician and the chair of the Department of Global Health and director of our Arnhold Institute for Global Health here at Mount Sinai at the Icahn School of Medicine. It's really our honor to be able to mark World AIDS Day today on December 1st. As both a pediatrician and an HIV researcher, World AIDS Day is something that is really close to my heart. And every year, I do find myself reflecting, especially on the children who, over the last 20 years, I have seen die from HIV, as well as, thankfully, the many children who are now adolescents and young adults who have been living with HIV across these years and what their life looks like now. But when I think about these lives that we have lost, and I know, especially on this World AIDS Day, I think many of us over the last month or so especially have been thinking about children's lives that have been tragically cut too short in lots of parts of the world right now with conflict and tragedies that cause all of our hearts to grieve. I think we naturally think about how we might do better. And when we think about HIV, I hope that in this way, thinking about children and thinking about HIV transmission, I certainly don't bring that up to be sad or make us, gloomy on this World AIDS Day, but rather I really hope that it can continue to be something that motivates us to figure out how it is that we can prevent and better manage HIV infections, no matter who is impacted by them anywhere in the world. I did want to take a moment today to honor a girl named Faith. For those of you who've known me, I remember and talk about Faith every single World AIDS Day on December 1st. That is a commitment I've made to myself. Faith was actually the first child that I lost to HIV as a physician. I cared for her in the hospital in Kenya, where I've worked for a lot of years at Moi Teaching and Referral Hospital in Western Kenya, where we continue to have this longstanding partnership that Mount Sinai is a part of called the AMPEP Kenya Partnership. And at that point in the early 2000s, when I was there in that partnership, we didn't yet have a system in place to be able to provide access to HIV care or to prevention of HIV. And our wards, even in the pediatric wards, were unfortunately full of patients who were dying of HIV. When Faith came into the hospital there, she was 4 years old and she only weighed 4 kilos, which is 11 pounds. Now, probably you don't need to be a pediatrician to know that a 4-year-old should weigh a lot more than that. That's what often, a baby who's not even 4 months would be weighing. And of course, seeing her tiny body, I suspected that Faith had HIV from the moment I laid eyes on her, and our tests showed that she did have HIV. And that meant that not only was I diagnosing her, but I was also diagnosing her mother, who was there with her. And indeed, Faith's infection from HIV came through her mother's body, whether during pregnancy or breastfeeding, we didn't know. And Faith died just 2 days after she came to our wards. And I was really, I will never forget, not only because she was the first patient that I lost to HIV, and I remember how her mother mourned. And then I remember still that right after she finished her initial wailing, she came to me and she thanked me. She thanked me for the care that I'd provided for her daughter. And she thanked me because I had given her mother a picture of Faith. We've been taking pictures of all the kids on the wards and giving them to their families with a Polaroid camera that we had. And I felt so horrible because I felt like I hadn't done anything. I hadn't managed to keep her daughter alive. I felt like I'd failed, but her mother was so gracious in thanking me. And the other reason that I try to honor and celebrate and talk about Faith every year is not only, because of, again, these ways that she marked my life and my career as the last 20 years have been spent working on trying to keep children living with HIV alive and thriving, and to prevent these infections, and to figure out how we can grow health systems that care for people living with HIV or that are set up to prevent HIV infections. But also December 1st, when we celebrate World AIDS Day, was Faith's birthday. So Faith should have been, I should have done the math in advance, but she was 4 in 2003. So she should be, what, 22 today? And so let's think about those birthdays, both the birthdays that have been lost to HIV and those we honor on this day, but also those who are having birthdays today, because we are able to either prevent HIV infections or keep those who are living with HIV and alive in ways that we couldn't before. Today, we're going to talk more about what it looks like in terms of ending the infections from HIV that pass from pregnant and birthing people to infants. This is unfortunately, as you're going to hear from Dr. Humphrey, still something that the world is very much struggling with on this World AIDS Day in 2023. And in fact, in a really sad irony, even this morning in our continuing Kenya partnership, our team in Kenya let us know that a young woman who was born with HIV, who's grown up and survived through childhood and adolescence, and is now a young woman who was pregnant with her first child, actually died in a cesarean section complication this morning from HIV, died in the middle of the cesarean section, but as she was trying to give birth to a baby that we had, of course, hoped would not be infected with HIV. And so whether it's, thinking about the ways that HIV infection or HIV exposure continue to cut too many lives short, the ways in which birthing is still so complicated and dangerous for people in resource-limited settings and people in places where systemic racism and oppression and colonial issues continue to not keep us safe and not create systems that are supporting these births and these infants in the way that we could. We want to mark this on World AIDS Day and again, recommit ourselves to changing where we can. Without further ado, let me introduce Dr. John Humphrey, who's going to be our speaker for today. So Dr. Humphrey is an infectious disease physician, and he's an assistant professor of medicine at Indiana University School of Medicine. I know Dr. Humphrey and have known him for quite a while because he too does both clinical work and research work in this AMPEF Kenya partnership in Western Kenya, where a number of schools, including Indiana University and Mount Sinai, have partnered with Moi University and the Moi Teaching and Referral Hospital, actually in a partnership that dates back to 1989. Dr. Humphrey attended medical school at the Medical School for International Health at Ben-Gurion University in collaboration with Columbia University's Medical Center. He did a residency in both internal medicine and in pediatrics at the Tulane University Medical Center in Louisiana. And then he did an infectious diseases fellowship, including a T32 fellowship and getting a master's degree in epidemiology and health services research that he did here in New York at the Weill Cornell Medical Center and New York Presbyterian Hospital. He served as the pediatrics clinician educator, leading the team and supervising both clinical work, education, and growing research work in the AMPEF Kenya partnership from 2016 until 2019. And now as an NIH-funded researcher, Dr. Humphrey does research on how to improve HIV outcomes for pregnant and postpartum people and their children in resource-constrained settings like the partnership in Kenya. So we're really excited to hear from him today to consider and reflect on how we can end AIDS for maternal-child health, where we are today in 2023 and what we can look forward to. So thank you and welcome to John.
Okay, well, thank you, Rachel, for that introduction. And thank you to the Department of Pediatrics and Global Health for this invitation to come speak here on World AIDS Day. I used to live in New York, actually, as Rachel had mentioned, and I had been here for my fellowship, and that was 8 years ago, and I haven't been back since. So it's great to be here again. And I have to tell you, when I came in this morning and went to the Pain Quotidien coffee shop, and all the memories came rushing back. And that was before I even had, started drinking the coffee. So, so thank you again for this opportunity to be here. What I'd like to do for this talk today is give all of you listeners an overview of the current state of the HIV pandemic as it relates to maternal-child health. So specifically from pregnancy through breastfeeding and the postpartum period for women and their infants. I'm going to start by talking about kind of more higher level data that's put out by UNAIDS and the World Health Organization. And then I'm going to use examples from some of the research that I've been involved with in Kenya to give you all a more kind of on the ground, nitty gritty understanding of the kind of the real world issues in HIV treatment for this special population. Whoops. So, okay, so first about me, as Rachel mentioned, I'm coming from Indiana University, from the small town of Indianapolis. I conduct research at the academic model providing access to healthcare, or the AMPATH program in Kenya. For those of you who may not know, hopefully all of you listeners do, but AMPATH is a large HIV care and treatment program that has been supported by the PEPFAR program and served several hundred thousands of people living with HIV at Ministry of Health facilities throughout the region of Western Kenya. There are currently more than 150,000 people living with HIV who are enrolled in care at these facilities, which are affiliated with AMPATH. The AMPATH consortium is basically a consortium of mostly North American universities or medical schools, which include Mount Sinai as well as Indiana University, who work together in collaboration with Moi Teaching and Referral Hospital and Moi University in Kenya in areas of care, teaching, and research, which includes HIV, but as well as many other diseases, including population health and a variety of specialties in pediatrics and medicine. For those of you that are not familiar with AMPATH, I would encourage you to go to the website and consider ways that you might be able to be involved, either as a trainee or even as a faculty member, or even as a tourist. When I was living in Kenya, I found that most people feel that when you come to Kenya, the safari animals are the most spectacular things to see, the lions and the elephants. But I have to tell you that I think some of the birds are the most spectacular sights on display there. There is a flyway that kind of runs from the southern part of Africa all the way up past the Red Sea and into Europe and through Kenya. So you can see these beautiful species of birds just in the environment. I also conduct research with the International Epidemiology Databases to evaluate AIDS. This is an NIH-funded consortium which pools HIV data from programs around the world, including AMPATHs, to understand the global epidemiology of HIV care and treatment. So I'm going to start out with a brief year in review. So as of the UNAIDS data for 2023, which is based on the previous year's data, there are an estimated 39 million people who are currently living with HIV. And this includes 1.5 million children, as well as 1.2 million pregnancies that are impacted by HIV every single year. There are also 1.3 million people who are newly infected with HIV this past year, and that includes 130,000 children. And actually about 50% or half of those new infections in children are occurring in just 6 countries: Nigeria, Mozambique, Tanzania, Uganda, the Democratic Republic of Congo, and South Africa. And actually about half of those new child infections are occurring during breastfeeding, while a minority then are occurring during pregnancy and the remainder during the peripartum period. And then there are an estimated 630,000 people that died from AIDS-related illness this past year alone. And when I think about that statistic, I am moved myself by a story of a boy who was hospitalized on the Moy Teaching and Referral Hospital ward some years ago while I was in Kenya. His name was James, and he was 12 years old, and he had presented to the hospital wasted and thin with some AIDS-related illness. His mom had died earlier that year, presumably from AIDS as well, and now his father, pictured there, was living with HIV. I find it, sometimes it's easy to forget working in an HIV clinic and seeing patient after patient, whether in Kenya or in the US here, that has a suppressed viral load and is literally thriving on antiretroviral therapy, to remember that AIDS is such a devastating disease that dismantled this boy's family and his childhood. And these are people that we commemorate and remember on World AIDS Day as well. There were new DHHS guidelines that were produced at the beginning of this year around breastfeeding for people and for pregnant or breastfeeding women living with HIV. And the guidelines now state that individuals with HIV who are on antiretroviral treatment with a sustained and undetectable viral load and who choose to breastfeed should be supported in this decision. And this replaces longstanding language that recommended that women with HIV avoid breastfeeding in order of avoiding the risk of mother-to-child transmission. Well, I don't have to explain to this audience the loss of that and the benefits of breastfeeding. So now this new data, as the guidelines state, are more responsive to community input and decision-making around breastfeeding, as well as evidence that suggests that in the setting of a sustained or undetectable viral load, that transmission from mother to child can be reduced to less than 1%. But not zero, as would be the case for sexual transmission. There was also a paper that was published this past April by CDC investigators called "Achieving Elimination of Perinatal HIV in the United States." And they used national HIV surveillance data to report on the status of HIV transmission in the United States. And they found that, in about 2010, there were roughly 4,500 cases of women with a pregnancy who were living with HIV. And compared to 2019, there were about 3,500, so about 1,000 less. Additionally, in 2010, there were 74 cases of vertical transmission or perinatal HIV acquisition among infants, compared to 32 cases in 2019. So 2019 was actually the first year that the United States achieved elimination of perinatal HIV transmission, which was defined a decade ago as less than one case per 100,000 pregnancies, or 100,000 live births rather, and less than one case per 100 pregnancies among women living with HIV. They also acknowledge that there are racial and ethnic disparities in these data, and that throughout this period, HIV transmission to infants of Black and African American women has been higher than among other groups. And this underscores the need for prevention focused on this population. And then finally, there was a large document called The Path That Ends AIDS, which is a UNAIDS document that details the current state of the HIV pandemic across the spectrum of populations, as well as the steps that are needed towards the goal of ending the AIDS pandemic by 2030. And one of the graphs from this report is shown here. This shows the number of new HIV infections among children aged 0 to 14 and antiretroviral therapy coverage among pregnant and breastfeeding women over time. So you can see here that the green bars indicate antiretroviral therapy coverage among pregnant and breastfeeding women. And you can see that increased from about 48% coverage in 2010 to about 81% in 2015. And ever since then, it's hovered at around the low 80s. And meanwhile, you can see in the orange line here that this is the number of new HIV infections in children. And this decreased fairly more rapidly in the early 2010, 2012. But since then, in parallel, the progress towards eliminating or reducing new infections in children has slowed. I want to take a closer look at these data and relate them to our data in Kenya. But before I do that, I want to point out the same graph from about 5 years ago in 2017, where you can see, the colors are different, but the meanings are the same. As you can see in the early 2000s that the coverage of antiretroviral therapy just was dramatically scaled up in the early 2000s, and with that, a very significant decline in new HIV infections in children. Which then is more or less stalling. I think one of the things that we need to acknowledge, in addition to commemorating the patients that have suffered from AIDS-related illness over the past years, are all the triumphs or all the successes that we've had. One way to look at this is sort of a glasses half empty view of the stalling progress. But imagine all of the cases of HIV infection in children that are averted year after year based on this graph. That's something I think we can really be encouraged about and motivated by to make it, towards ending the AIDS pandemic. In Kenya, they make a point of celebrating these successes. And this is a picture of what's called a Hay graduation party, or HIV-exposed infant graduation party. It's typical or routine care that children are breastfeeding in Kenya, and they have their final HIV test after cessation of breastfeeding, which then the HIV transmission risk is no longer there. And if they test negative, which is usually about 18 to 24 months, they then hold a graduation party. They've graduated from the prevention of mother-to-child transmission of HIV services, or PMTCT services program. And so they literally dress these 2-year-olds up in these graduation gowns. They have a conga line here. These are groups of their mothers, celebrating. And this is one of the mothers here standing next to a mentor mother who is a woman living with HIV, who also plays a pivotal role in counseling and helping these women through the challenges of the whole process of preventing HIV transmission. And then, of course, here's one of the proud graduates himself. The UNAIDS goes into some kind of superficial depth on the reasons for new vertical infections in children, and they group them into several 4 categories here. And so you can see here's globally, and this is Eastern and Southern Africa, which includes Kenya and accounts for really half of all pregnant women living with HIV in the world. And you can see here that the red bars indicate the mother acquiring HIV during pregnancy. Well, that's a little different than sustaining antiretroviral treatment, because the cure for this problem are prevention interventions, right, to reduce HIV acquisition. But then in the orange here, you can see that the mother did not receive antiretroviral therapy during pregnancy or breastfeeding. The teal indicates mothers who did not continue antiretroviral therapy during pregnancy or breastfeeding. And then the blue indicates the mother that was on antiretroviral therapy, but who did not achieve viral suppression, which is critical for reducing the risk of vertical transmission. Our team in Kenya has spent a considerable amount of effort trying to understand the factors that are driving these failures in what is called the cascade of HIV care for this population. This is a retrospective cohort that we conducted among all pregnant women living with HIV who were enrolled in care at Moi Teaching Referral Hospital in Kenya from 2015 to 2019. Moi Teaching and Referral Hospital is the headquarters of the AMPATH program. It is the 2nd largest national referral hospital in the country. And what we found through this analysis was, first of all, that retention and care during the postpartum period declines over time. So this is defined as for this analysis, as any visit that was attended within 90 days before or after the 6, 12, or 18-month anniversaries after delivery. And you can see that by 18 months, about 1 in 4 women are no longer retained in PMTCT care. You can see that also that this phenomenon is mostly driven by women who are newly diagnosed with HIV during pregnancy. So women that come in to antenatal clinic during pregnancy, and along with their routine labs, have an HIV test that turns out positive. You can imagine the impact that this could have on a person who is otherwise healthy and excited about a pregnancy. One of the limitations of these data, however, is that you don't really know what happens to people after they become lost to follow-up. Much of what what's really known is just what is recorded at the clinic, what's measurable at the clinic. So once someone leaves a clinic, whether they may be in care elsewhere, whether they may not be in care at all, or whether they're even deceased, is often not known unless you conduct special investigations to try to find and ascertain these outcomes. This is important, though, because when UNAIDS makes these estimates of antiretroviral coverage, these are estimates that are modeled on like a national or population level. And so, the people, when they disengage from a clinic or become lost to follow-up, they don't just disappear from the nation. They need to be accounted for some way in the model. And so understanding the actual outcomes of people who become lost to follow-up, their antiretroviral treatment status, is important for not only care programs, but also refining estimates of HIV, for HIV transmission and the population at the larger kind of national level. So to understand this, we undertook a prospective cohort called the study called the IDEA Kenya PMTCT study. And so this was conducted at 5 different facilities, district hospitals affiliated with AMPATH in Western Kenya. And we enrolled women who were living with HIV, who were at least 18 years of age, and who were pregnant and enrolling in antenatal clinic. And then in parallel to that, we conducted community tracing in collaboration with the facility staff and community health workers to find individuals that had enrolled in antenatal clinic, but then become lost to follow-up prior to 6 months post-delivery, which we defined as more than 90 days since their last attended clinic appointment, having not returned to clinic. We followed up this cohort and determined their outcomes at 6 months and again at 3 years after delivery. And I will present the findings from that in the next few slides. So first of all, this is the comparison of the 333 women that were enrolled in the cohort, stratified by their retention status by 6 months post-delivery. So the women that were retained in care here on the left, and then women that had become lost to follow-up here on the right. And you can see several differences emerging between these two groups. The first is that women that had become lost to follow-up were on average younger than those that were retained in care. Women that had become lost to follow-up were less likely to have disclosed their status, their HIV status, to anyone, or even specifically to their partner. Women that had become lost to follow-up were more likely to have been newly diagnosed with HIV during the pregnancy. Of course, this is confirmatory of the prior study that I showed. And women that had become lost to follow-up were less likely to be virally suppressed, which again is key to preventing vertical HIV transmission. And then finally, women that had become lost to follow-up were far more likely to have suffered a miscarriage compared to those that were retained in care. Here are the outcomes of the infants of the women stratified by the maternal retention status. And you can see that, this is a breastfeeding population. Breastfeeding is recommended. However, exclusive breastfeeding is higher among those who were retained in care compared to those who had become lost to follow-up. And you can also see that HIV-free survival is higher, far higher in those who were retained in care compared to those who were lost to follow-up. And I think, at some point, in some sense, this is sort of intuitive, right? You would think that people that stay in care would have better outcomes than those who become lost to follow-up. And I think in some sense it is intuitive. However, you have to remember that the only thing that the clinic is really seeing is this column right here. The only outcomes that they know are the people that are retained in care. But if you take a more societal or community perspective on all of this, these people certainly matter, right? And more needs to be done to try to reduce HIV transmission among this group. We asked women, about the reasons for leaving the study facility and not returning. And we stratified this by women that had actually been disengaged from care, meaning that they had not reported engaging in any other clinic. And then looked at those that had silently transferred. So we reviewed their actual appointment cards and patient-held medical records and saw that, in fact, they had actually they were in care at another facility, but had not told their prior antenatal clinic or postnatal clinic that they were transferring out. So they were in care. And this in the literature is often referred to as silent transfers. And you can see that, first of all, here, that transport cost or difficulty with transport is a major barrier for this population, but it's more common are more often reported among those who had silently transferred compared to those who are entirely disengaged from care. In contrast, however, HIV stigma and disclosure was more often reported among those who were disengaged from care entirely compared to those who were silently transferred. And then change of residence was more common among silently transferred compared to the latter group. We compared several of the clinical outcomes amongst these two, and these are smaller numbers, so there wasn't any statistical significance here, but you can start to see that there are potential differences in clinical outcomes between these two groups as well, which goes to show that, loss to follow-up is important, but it's not necessarily important for everyone, because a portion of these people, about 1 in 3, will actually be in care elsewhere and potentially be doing better. We also conducted qualitative interviews with 40 of these women and found that the barriers to retention and care are actually quite diverse. And there isn't just one barrier that can be addressed through one targeted prevention intervention to improve loss to follow-up. More likely, it's going to require a package of services or multi-component interventions to address the myriad of different reasons that women cite for that influence retention in care. This is a graph that is showing the outcomes at antenatal clinic enrollment, and then at 6 months post-delivery, and then at 3 years post-delivery. And the heights of each of these columns is proportional to the number of patients in the cohort that fit into each of these groups. And then the width between them, this is of course not to scale. But you can see, first of all, that most of the women that remain in care, who are retained in care by 6 months, remain retained in care at the study facility by 3 years. So even after completion of PMTCT follow-up. However, about 10% of them end up transferring out by informing the clinic that they're transferring, such as a document to transfer, and are actually in care at the other facility, which is encouraging. We found, however, that another 5% or so had become disengaged from care, and another 5 to 10% we were not able to determine the outcomes of, whether they were alive, dead, or in care or not, because we were not able to conduct tracing at the 3-year mark for these individuals. We were not able to re-encounter them. Then among women who had become lost to follow-up, you can see that actually more than half of them had re-engaged in care at the facility in which they had initially attended antenatal clinic, which is important because if we were only to look at some cross-sectional measure of retention, we would be missing this dynamic phenomenon that's happening with retention and engagement, where women go in and out of care and transfer between facilities pretty dynamically kind of over time. You can see that the same phenomenon happened among women that had silently transferred out. So they were in care at another facility, and actually a proportion of these women are transferring back into this facility in which they had enrolled in antenatal clinic and were retained in care there. However, another third of them had silently transferred out, and we were not able to re-encounter them. These are some of the characteristics of the children at 3 years. You can see foremost that even at 3 years, HIV transmission and mortality are higher in the children of the loss to follow-up group. However, we were not able to determine the outcomes of 23% of this group, which may mean, given the vulnerability of this population, that these estimates are underestimated. So where do we go from here? Up to this point, I've shown data that from UNAIDS that suggests that PMTCT progress seems to be stalling to some extent. In addition to this, in the same report, they indicate that funding is also stalling. This is the red bars indicate domestic funding for HIV care globally. The teal here is US funding, and then the blue is the global fund, and then this is other funding. And year on year, you can see that the needs for HIV funding is not being met in order to achieve the anticipated goal of ending the AIDS pandemic by 2030. I've talked about how maintenance on antiretroviral treatment and viral suppression are challenges. And I've talked about how those who are lost to follow-up have worse outcomes in general than those who remain retained in care. As I reflect on this graph here and the lack of progress, I think that to some extent, it reflects the limitations of the current status quo facility-based model of HIV services that have been in place for 20 years now and that work effectively and have yielded a lot of gains with this population, the people on the top half of this graph here. But it's not working, and it hasn't been working for the people down here. These people need services that can be adapted to their needs and their preferences. And this is the way I think that we're going to really, I think, achieve more gains in ending the pandemic, whether funding is allocated additionally or not. I think this resonates well with this year's World AIDS Day theme that was put out according to UNAIDS and the World Health Organization, which is let communities lead. And I think that, again, this is reflective of, well, I'll say, for more than a decade, as I've reviewed the PMTCT literature, it has overwhelmingly focused on identifying the characteristics of patients that can be used or exploited to identify some risk factors that can be then targeted for interventions. But I think in some way, it's time to turn that equation around and start looking at the characteristics of health services or health facilities that have been failing patients. And there was far less in the literature about that. And I think that letting communities lead, passing the baton from the health facility to the community is the way forward. And I can see kind of many ways that this is starting to emerge in HIV services and at conferences in the HIV field, and particularly over the past few years. This has certainly been increasing at the AMPATH program in Kenya. You can see a variety of community-based groups and services that are being implemented more commonly. This is a group of called a chama, which is a group which literally means group in Swahili, which is a group of pregnant women that meet together in the community regularly throughout their pregnancy, in addition to a nurse from the facility, as well as a community health worker. And they use these groups to encourage one another to deliver at the facility through challenges associated with breastfeeding, the importance of immunizations, and considering family planning. And these have been scaled across Western Kenya and have been sustained for several years now and are thriving. There are other great opportunities for layering on additional services like microfinance groups or even care for chronic diseases apart from HIV, like hypertension or diabetes. I think there's a need for more peer support programs that are community-based to meet people where they are. And this includes the need for psychosocial support and mental health, which has been a long neglected area of HIV care. I think there are ways that HIV services are being transformed and moved into the community through technologies, and this includes mobile health or mHealth, as well as telemedicine. And then finally, there are several tailored treatment approaches, such as integrating HIV and reproductive health or mental health or family planning services all together to ease the burden of care for patients. I'll go into differentiated services and preference-based services during the second part of my talk here. But finally, I want to point out that I think there's also a need for supportive policies and funding that fund community-based initiatives rather than those that are facility-based. So differentiated services is one of the major ways that global HIV services have been transformed over the past really 5 years. So this is a World Health Organization endorsed strategy to improve the quality and efficiency of HIV services. And essentially, it simplifies HIV services for patients who are clinically stable or those who are established in care, meaning that they're virally suppressed, able to adhere to ART and to their scheduled appointments, which then allows for kind of less intensive services to be provided to these groups, such as rather than coming to the facility every month or every 3 months, to receive antiretroviral treatment in the community or through a community group that meets once every 6 months. There are also fast-tracked appointments, such as patients that are clinically stable or established in care can go to the facility just for an ART refill and then be on their way, rather than having to dwell at the facility for 6 or more hours, which is unfortunately all too common. This would then allow for the intensification of services for patients who are not clinically stable or really not established in care, to use less potentially stigmatizing language for them. And this has been highly successful at AMPATH. Over half of AMPATH clients have been enrolled in differentiated services. But it wasn't until the 2022 Kenya guidelines that pregnant and breastfeeding women were eligible for inclusion in differentiated services. Up until this point, pregnancy and breastfeeding has been an exclusion criterion for differentiated services. We wanted to understand what women's preferences are for services. And so we sought to look at this through a discrete choice experiment. On the one hand, you might think, well, through qualitative research that we've done, most women feel that preventing vertical transmission is of utmost concern. Everyone cares about this, right? But on the other hand, who wouldn't like to have less frequent appointments? So we felt that there was equipoise for a study that actually looked at what women's preferences would be around this. So we conducted a prospective study at 5 facilities, the same 5 facilities that I'd showed for our IDEA Kenya PMTCT study. And we enrolled women who were pregnant and within 18 months postpartum. And we asked them a survey called a discrete choice experiment. And so this is a method of that's common in the marketing research world that allows you to quantify individuals' preferences for various goods or services. You can imagine when you go to the store to pick out, the next iPhone, that there are various sizes, the screens have different resolutions, the prices are different, the storage is different. All of these are different attributes of one product that you have to kind of weigh against each other. But combined, they have one, you will end up picking the combination of attributes that provide the greatest utility to you, the greatest share of preference. So you can apply this same model in looking at various components of health services. So here are essentially the attributes that we used in this experiment. We looked at the clinic visit frequency during pregnancy and during postpartum, whether a meeting with a mentor mother or peer counselor would occur at each visit or not, or just not at each visit, but as needed, and the same with a clinician. And then the cost per visit was stratified by 0 shillings, 50 shillings, or 100 shillings. 100 shillings is about, $1, $1 US. And so then we asked women a series of choices. So which clinic would you choose between these two? Well, clinic 1 has visits during pregnancy every month, and the postpartum visit would occur every month. But the cost of the visit would be 50 shillings, for example. But clinic 2 here, well, you can see that the postpartum visits are spaced. They're only coinciding with the infant's immunization visits, whereas the cost of the clinic visit would be 0 shillings, would be free. So you might say, well, I'd pick clinic number 2 here. Well, then we'd ask another set of 2 choices. So now clinic 1 has visits during pregnancy every month, but the postpartum visits only with immunizations, and the cost is 0 shillings. But here now, the clinic visit during pregnancy is every 2 months, and the postpartum visit is the same, and the cost is 50 shillings. So now you can see where you have to make trade-offs into choosing which of these you would prefer. And by doing this repeatedly, essentially about 12 times in this study, you can arrive at like a quantitative estimate of what women most value relative to these attributes that are shown. So we found that, well, first of all, in this low resource setting with low or low socioeconomic status, that the cost was a very important variable for women. Women, by and large, preferred not to have to pay even 50 shillings to be able to come to clinic. But the second most important among these was having less frequent clinic visits during the postpartum period, which the standard of care is a monthly visit all the way through 12 months postpartum, which is burdensome for women. And clearly they feel like having less frequent visits would be more preferred and even more preferable than who they see at the visit. So I think that there are lessons here around what women value when they come to the facility and why they come to the facility that I think we can take to improve services. Another thing that you can do is kind of model what the maximum utility model would be using these attributes. And we found that the maximum utility model would be pregnancy visits every 2 months, postpartum visits only with immunizations, a mentor mother and clinician visit at each visit, and the cost was standardized at 0 shillings against the conventional care model, which is the current standard of care. And by modeling that, we found that actually 75% of women would prefer this maximum utility model, which is kind of analogous to a differentiated service delivery model, which would provide kind of less intensive services for women compared to the current standard of care. We also then looked at, well, what factors might be associated with a preference for this maximum utility model over the current standard of care. And we put in a variety of patient level factors here. However, in the multivariable analysis, the only thing that was significantly associated with preference was the facility that women came from. And you can see that at Kitale Hospital, women had a significantly higher preference for the maximum utility model. However, at Haruma Hospital, women had a preference for the conventional care model. These are different facilities. One is a smaller sub-county hospital, one is a larger teaching hospital. I think this also goes to show that we need to put more effort on understanding the experiences that people are having at the facility and the types of services they're being provided as basically predictors or ways to improve HIV services for this population. And another example of kind of understanding the importance of patients' preferences. Some of you kind of knowledgeable about the HIV going-ons may be familiar with this scenario back about 5 years ago, where dolutegravir given at conception was associated with a preliminary risk of neural tube defects in infants. And this was reported by a study out of Botswana. And it caused kind of a very significant kind of shift and abrupt shift in HIV policy. Dolutegravir is a type of antiretroviral treatment called an integrase strand transfer inhibitor. This is the first-line treatment for HIV care in the United States. It's been that way for over a decade now. And in about 2018, it finally had become generic and was being rolled out globally. And so this study was undertaken during the early phase of the rollout in Botswana, and they found this potential association. So then within a month after that, the World Health Organization issued an interim guideline restricting the use of dolutegravir to women of childbearing age who were using effective contraception. And this created considerable controversy among rights groups and other stakeholders at the time who felt that this policy was preferencing the health of the infant over the rights and the health of the mother. And so we looked at this through global IDEA data, looking at the cumulative incidence of dolutegravir uptake both before and after the World Health Organization's interim guideline. And we found that in fact, indeed, there was a disparity in dolutegravir uptake among women of childbearing age 16 to 49, after this interim guideline compared to other groups. About a year after that, the World Health Organization policy was updated to recommend dolutegravir for all, and there was new data that has since come out that's shown that this risk of neural tube defects was lower than initially expected. We also looked at whether there was any change in effective contraception use among this population, which may have kind of informed the lack of uptake of dolutegravir among women of childbearing age. And we found that, in fact, there wasn't really any change in effective contraception use either. So this further illustrates some of the challenges of tying contraception use to antiretroviral treatment policy. In my last few slides here, I want to overview a brief study I want to briefly overview a large study that we've been lately working on in response to this, in response to really the need for pharmacovigilance systems in countries with high HIV burdens to detect potential associations between adverse pregnancy or newborn outcomes and antiretroviral and other medication exposures. So we implemented the Measuring Adverse Newborn and Congenital Outcomes, or MANGO study. And this is basically a birth surveillance program that we've set up at Moy Teaching and Referral Hospital in the maternity hospital on the campus, which is pictured here. And it involves kind of three main cohorts. So one is a prospective cohort where we recruit pregnant women living with and without HIV and follow them through the time of delivery and conduct community tracing to understand their delivery outcomes if they end up transferring out of the facility or deliver at home. And the second is a cross-sectional, involves cross-sectional data collection for all of the deliveries at the facility, and we call that C2. We also finally take photographs through written informed consent from the parents to document the major congenital abnormalities that are detected at this hospital. And then we have these reviewed by an expert in clinical genetics that's based at Indiana University and reviewed by a panel of a neonatologist also at Moy and pediatrician. So far, this study has been going for a few years now, and we've been enrolled over 1,000 women in the prospective cohort and been successful in capturing delivery outcomes for the vast majority. And then in the cross-sectional cohort, there are now more than 23,000 deliveries that are captured in our database. And this is a basic overview of some of the characteristics of these cohorts. We've then sought to combine data from this study with a parallel study that's happening in South Africa in order to achieve larger sample sizes that can be useful in kind of detecting or teasing apart very rare events such as birth defects. So in an analysis that was published or that was presented earlier this year at CROI, we combined data from Kenya, about 15,000 deliveries, and about 5,000 deliveries from South Africa. And we found in summary that there was not a significant association between HIV or dolutegravir exposure and congenital abnormalities, which is important because this provides reassurance about the safety of antiretrovirals for this population and is helpful to help ensure equity in antiretroviral distribution now and in the case of future antiretrovirals that may be deployed, over the coming years. Wow. Okay. I feel like I've covered a lot of ground here over the past 45 minutes or so. I think we've gone through the progress in HIV and maternal-child health, both in the United States, which has been terrific, and also in places like Kenya, as well as the challenges that are ongoing. And I hope that now you have sort of a more kind of real world understanding of the current challenges in this field globally. We've also talked about various strategies to transform HIV services to end the AIDS epidemic by 2030. And I think that a big part of this will be, consistent with the message of this year's World AIDS Day, which is to let communities lead. I have many people to acknowledge and thank. Of course, everything that I've presented today is the product of a team of people in Kenya, as well as Indiana University. These are some of the people from our team over the years. Here I am sort of in the back on off center. But yeah, thank you again for your attention, for coming to this session, and happy World AIDS Day.
I could ask a question to start John and figure out if there are a few questions there. You might have to repeat though what I say or anyone else in here because it might not pick up. So I think as you pointed out, it's a really incredible and terrific progress in our guidelines globally that I think it's a terrific change in the guidelines globally that does allow and support breastfeeding as a choice, and all the ways in which not only do we want that to be a choice, but that it can be protected and supported and not seen as necessarily a lesser option. And I think increasingly too, we in a way that I think is healthy, we've started to, have the idea that sort of fed is best for babies. That, we know as pediatricians all the amazing things about breast milk, but also that what's even more important is making sure a baby is fed. I wonder if you could spend just a minute talking about kind of the trickiness of the mixed feeding and what is known about that right now. I saw, in your data, and of course I know this a little bit, but like where, there's breastfeeding, protein, and then like mixed feeding, but why maybe we think that still is a challenge, and to what extent we know whether it is or is not a problem related to HIV transmission.
Oh, yeah, sure, Rachel. Thank you for your question. Yeah, so I think, to start out regarding mixed feeding, there's data that's kind of over 10 years old by now that suggests that if you introduce mixed feeding too early in an infant's life, that this can be associated with changes in the intestinal mucosa and gut microbiome that can increase the risk of mother-to-child transmission or vertical transmission through basically, ingestion of breast milk and then easier translocation of HIV across the intestinal wall. So it's recommended to not do mixed feeding, essentially, or at least to adhere to exclusive breastfeeding for the first 6 months, followed by introduction of porridge and so forth. So and in these data, actually, some of the other people on our study team had commented on that as well, that we thought that people weren't doing mixed feeding anymore, but actually there were a few percent, about 5% in those that had become lost to follow-up that were. And this was, I think, some difference between asking women through face-to-face surveys compared to just routinely collected data that's available in the AMPATH electronic medical record, as far as the discrepancy and findings there. But I do think that, all of these are sort of open questions now, given that we live in a different era of antiretroviral treatment. Now I think the same can be said of the need for zidovudine prophylaxis of the infant. These are studies that that could be looked at again, and that, dolutegravir and viral suppression is so powerful right now, and if one adheres to it, we know that it dramatically reduces the risk of mother-to-child transmission, even in Kenya in a breastfeeding population. So yeah, I think it's a good question. There's one question on the chat here, which is from Alexandra Coria. I worked in HIV care in East Africa and found that as we tried to implement differentiated services, there were big barriers that were supply chain related. Couldn't refill meds for more than a month, government hesitant to recommend longer follow-ups in the national guidelines. Can you speak to approaches you've seen to address upstream barriers in policy, economic, et cetera, to a differentiated care or maximum utility model? Yeah, that's a great question. I think that has been, I can't speak specifically to these challenges with supply chain. This is kind of a little bit above my the space that I work in right now. But it's absolutely true that, particularly people that are on like second line antiretroviral therapy, they have limited supplies of these. And so it's not possible to give someone a 6-month supply of antiretroviral treatment because really they get supplies kind of periodically, and they need to reserve what's available to distribute, even or equally to everyone in the program. I think that these are, the first thing that needs to change is the policy around it. Right now, the standard of care for pregnant and postpartum women is monthly visits. And for good reason. No one wants to risk doing something that might increase the risk of vertical transmission. But clearly, we need to do something, because vertical transmission right now is still happening. And so I think that only through data and understanding women's preferences, and eventually through studies that demonstrate that these less intensive models of service delivery are equally effective as the prior status quo, are we going to see the policy change? But yeah, those are good points too. Thank you.
The question I have is, do you see on the horizon a space for immune-based interventions, either in vertical transition or for pediatric HIV care, like at the same time, treatments that might complement existing or effective?
Gosh, well, I mean, I know these things are by on the horizon. I'm aware that these things are already sort of in kind of in development, like neutralizing antibody type things. Are you talking about?
I'm asking in the sense of, do you see that as a need in the space that you're operating in, or how applicable that might be applied?
Yeah, I mean, I think from, well, you know, from my perspective as someone that works in kind of the HIV services space, I see that a lot of the barriers that that still exist are ones about, you know, women's mobility and stigma and fear of HIV disclosure, poverty, that can all be addressed through, you know, a variety of different interventions. It may be that long-acting cabotegravir or new treatments will absolutely help alleviate some of those barriers. But kind of in other senses, you know, we know that dolutegravir works to prevent mother-to-child transmission. So what are other ways that would be feasible in such a resource-limited setting to scale up, you know, to close the gap in dolutegravir for this population, for example? Let's see, I imagine one last question here. Okay, I imagine most mothers cannot afford infant formula. If they cannot breastfeed to prevent transmission, are they linked to programs that can provide infant food for their babies? Yeah, so I mean, well, I can speak to the AMPATH program specifically, but yeah, most women, you know, by and large are able to breastfeed. And if women are not, then there is assistance through the clinic that can help them with that. One of the challenges, of course, with giving infant feeding, and part of the reason why breastfeeding has been recommended all these years in Kenya is because of the risk of mixing formula with unsafe water. And so they've found through modeling studies that actually the risk of mortality through formula feeding with unsafe water is higher due to diarrheal diseases than it would be due to HIV through breastfeeding. So this is part of the reason why breastfeeding is recommended. All right. Can you speak to how HIV stigma and discrimination impact the way a mother may seek care and treatment services for herself or her child? Yeah, I mean, gosh, it's, of course, you know, imagine just the scenario of a healthy woman who is maybe pregnant for the first time and is like 24 years old, and she comes to the antenatal clinic as she you know, as she has been taught to do the right thing, and she gets a urine test and a syphilis test and an HIV test, and bam, the HIV test is positive. Imagine the implications that this may have on her life. You know, she's thinking not only about her own health, but about her relationship with her husband. You know, what if her husband finds out that she has HIV? He might feel that she's the one that brought HIV into the family, where it may be the other way around. He may be living with HIV himself. If this woman is dependent on her husband for food and shelter, you can imagine, you know, the utility equation that would go through her mind and saying, would I risk that by telling my husband I have HIV, or would it be better to keep that a secret and at least maintain my my shelter? You know, these are real questions that that women in this setting deal with, and yeah, stigma and discrimination impact their decision making significantly. So I think it's, yeah, really important.
I'm sure you could talk about that for another hour, but I know we should probably draw us to close. So thank you again. Oh, sorry. We're going to draw our attention to a close, even though we know we could talk for a lot longer about these critical issues. Thank you again to Dr. Humphrey for presenting for us. Thank you to everyone who joined us for World AIDS Day today, both in person and online. And we'll conclude our time today. Thank you.
Thank you all.